those terms. So with treatment-resistant patients, the name of the game really is to get people onto clozapine and to get them to continue taking it, and that's obviously easier said than done. There's a lot of fear around clozapine, not just patients who are fearful of it, but psychiatrists often are as well. So there's a belief that it's very dangerous. Well, that's fair enough. It is quite a dangerous drug. Probably not as dangerous as people think, though. A lot of patients think that it's going to be addictive. It's going to make them fat. Fair enough. It probably will do. They think they're going to become a zombie. There's also this feeling that when you're put on clozapine, you're on the scrap heap. It's a drug for people that are on the scrap heap who've been given up on. This last one is a problem as well, because although we all see when we put people on clozapine how much they improve, and we're comparing them, of course, with them being very unwell before they were on clozapine. But nevertheless, there are a lot of people who are walking around on clozapine who are still quite symptomatic, because not everyone has a full recovery. And those people aren't always great adverts for clozapine. So patients will look around, they'll see people on clozapine and think, well, I don't want to be on clozapine if that's the sort of person that's on clozapine. So a lot of people who don't want to take clozapine, the reason given is often because of the blood tests. So some people will have a genuine needle phobia, and for those people, one trick that we use is to use Emla cream, which is used in paediatrics. It's basically lidocaine, prilocaine cream, which is you put it on 30 minutes before you take the blood, and it basically relieves the pain. Another technique, which again we've borrowed from paediatrics, is using a finger stick to do the blood tests. So you use a finger stick just like you would with a BN stick. You put it in a paediatric blood tube, which are those very tiny ones that they use in neonatal services. And for our lab, you have to get it to the lab within an hour. Most labs, you have to get it there very quickly, and then they'll be able to give you a full blood count from that. In our experience, that normally you only have to do that for 2 or 3 times, and then the patient usually starts accepting a regular blood test. The other thing that we sometimes use is a butterfly. Even if the butterfly is the same gauge as the needle that you would otherwise have used, the length of it is smaller, and some people get put off by the length of the needle, although of course it's the diameter that really is relevant in terms of pain. We also use benzodiazepines in people who are fearful of taking clozapine or are very agitated when they're taking clozapine. Sorry, not taking clozapine, when they're having their blood tests. So we'll give some diazepam or lorazepam, say an hour before the blood test is due. We also use a lot of behavioural approaches, linking blood tests to leave and to other things like that. In some circumstances, if everything else does not work, then we do take blood under restraint on our unit. There is, if the person's under a section 3, then you do have authority to take blood under restraint under section 62 of the Mental Health Act, which is the part that deals with ancillary treatment. So because you're taking the blood test in order to give a treatment, it's permitted under the Mental Health Act. The other thing about venipuncture to say is that we always try and reduce any unnecessary blood tests, because patients are on clozapine. They're on blood tests weekly, so there's no excuse unless there's an emergency for giving them for bleeding them at any other time other than once a week. The other thing to say about blood tests is that although blood tests is often the reason given for not wanting to take clozapine, in some cases people say they don't want the blood test, but actually it's the clozapine that they don't want. And so the conversation you need to be having with them is not a conversation about needles. It's a conversation about clozapine and what their problems are with clozapine and what their concerns are about it. And lastly, there are people also who have delusional reasons for not wanting to be bled because they think that you're going to be using their blood, storing it or drinking it or whatever it might be. So those are obviously that's another situation where the conversation you need to have is about that, not about Emma cream and things. So a few years ago, David Taylor from here did a study where he just looked back over all of the people who've been started on clozapine over the past 10 years or so at the Maudsley and looked at the reasons for discontinuation of clozapine. And in about half of them, this red part here, was discontinued because the patient had stopped taking it. So you don't always know why that is. Often it'll be because of tolerability or because the patient feels they've got better, etc. In about a third of them, it was where adverse effects were particularly written in the notes as the reason for stopping. In about 13%, the reason for stopping was because the patient had died. And hopefully, none of those, or very few of those, would have been because the clozapine had killed them. It was because it's indicative of the fact that clozapine, once you're on it, you tend to stay on it. So it's a lifelong treatment. People keep taking it until they die. And in only 2% of cases was clozapine deliberately stopped by the clinician due to lack of efficacy. So why do people, what side effects do make people stop clozapine? This was a study that was done about 10 years ago, 12 years ago now, where they simply just asked patients what side effects trouble you when you're taking clozapine. And they gave people a list of side effects and asked them to endorse the ones that they were troubling them. And the one that came out by far and away as the most troubling is actually hypersalivation, which is quite a surprise. It was quite a surprise for me when I read that. Hypersalivation is a big problem for patients. It's a big reason for them not wanting to take clozapine. People find it embarrassing to be dribbling during the day. They find it distasteful to wake up with a wet pillow, and also it can be life-threatening. We know that there's a big increase in rates of pneumonia in clozapine-treated patients. And probably at least some of those are aspiration pneumonias from people swallowing or aspirating their saliva at night. And patients will quite often report waking up at night and feeling their mouth is full of saliva or even choking on saliva. So I think one thing that this slide shows is that the side effects or the things that we worry about as doctors about clozapine are not the same as the things that patients worry about. So as doctors, we tend to worry about, quite rightly, the medically serious things, the things that are going to kill our patient: neutropenia, cardiac problems, diabetes. But patients often aren't particularly concerned about those things. They're more worried about the day-to-day and the much more common side effects like hypersalivation, sedation, incontinence, and the need for blood tests. So general principles of clozapine prescribing are it's the old adage of start low, go slow. Use the lowest effective dose. It's very important to ask about adverse effects. I know that sounds obvious, but I always forget to ask about adverse effects, and particularly about things like constipation, which patients generally won't volunteer because it's embarrassing, and so it's important to make sure you ask about those things. And also, by asking about adverse effects, it shows the patient that you're taking their concerns seriously, and that you're not just dismissing them, which is the worst thing that you can do if you want someone to take clozapine. There are some adverse effects which you can legitimately reassure people about, things like postural hypertension, which tends to be very short-lived at the beginning of treatment. To some extent, sedation tends to be much worse at the start of treatment and improves after that. Another general principle is to use blood levels to look at compliance and to make sure that you're not giving people a toxic dose. And when adverse effects occur, it's important to treat them aggressively. And so what I'm going to do now, the next part of the talk, is I'm going to be going through common adverse effects, either ones that are common or that are medically serious, and particularly ones that are reasons for people not to take clozapine or not to want to take clozapine. And I'm going to tell you what we on the unit have used and found helpful. So a lot of this is not particularly evidence-based because not many people do randomized controlled trials on treatments for side effects. So a lot of this is gleaned from our own experience over the years. So sedation, practically everyone falls asleep when they first take clozapine, and you can more or less reassure people that that will improve. It doesn't always completely go away, but it does almost always improve. If it is becoming a problem, or if the patient's threatening to stop the clozapine because of it, then you can slow down the titration. We have a standard titration which is over 2 weeks, when you go up to 300 milligrams over 2 weeks. But actually, probably on about 50% of patients, because we get a lot of people restarting clozapine because of side effects, we will slow that down. We'll do it over a month instead of over 2 weeks. An asymmetric dose split where you have 2/3 of the dose in the evening and only a third in the morning is often very helpful if people are complaining of sedation during the day. You can actually give it all as in one dose. So the reason that we tend to give it twice a day is just because we don't like to give a big bolus of clozapine all at once. But the half-life is long enough that you can only give it once a day if you have to. Reduce other sedation medications. So it's very easy to kind of to forget to cross off things like benzos and things. When people go onto clozapine, we almost always withdraw them off all of their benzos gradually because they don't need them. So obviously it's important to see what else they're on that could be sedating them and to reduce or stop that. And if sedation continues being a problem, then check the plasma levels. Hypersalivation, it's probably worse at the start, but actually it probably does persist in a lot of patients as well. As I mentioned earlier, it's socially embarrassing, can be life-threatening. It's certainly under-recognised, and the mechanism of it is still unclear. So if somebody does have hypersalivation, it's important to check the plasma levels first of all, make sure they're not toxic, because it can be a sign of toxicity. So we got very interested in this, particularly after seeing that data from showing that it's the side effect that patients complain of the most. So about 4 years ago, Rebecca Syed, who was then here, did a Cochrane review on treatments for hypersalivation for clozapine-treated patients. And actually, to our surprise, she found 15 studies. We weren't expecting to find that many. But most of them were from China, whereas you probably know clozapine is used first line, and a lot of clozapine research comes from China, but a lot of it is not all that great quality. So that showed limited evidence for some antimuscarinics and for some Chinese remedies. Of course, the thing that we tend to use in the UK is hyoscine, and the BNF even lists clozapine-related hypersalivation as an indication for hyoscine, even though there's no evidence base for it. So we've actually just finished an RCT looking at hyoscine versus placebo in clozapine-treated patients as a treatment for hypersalivation, and we should hopefully be in the next couple of weeks. We should be starting the analysis of that, so we should have some results from that. Clozapine, another antimuscarinic, which again we use if hyoscine hasn't worked. Sometimes clozapine will. Amisulpride and sulpride augmentation of clozapine can be effective in reducing hyoscine. We don't use that as much now as we used to, for reasons I'll go into later on. And then finally, there's a combination treatment that we sometimes use, which has got a clinical trial favouring it. Benztropine, which is another antimuscarinic, and terazodone, which is an alpha-1 blocker. And you give those two in combination. If you look in the MORS prescribing guidelines, you'll see the doses. I've forgotten them at the moment. And we've had a few patients who've responded to that and haven't responded to antimuscarinics on their own. Tachycardia is a very common problem in people with who start clozapine. In fact, I think it's another one of these sort of unrecognised problems, because in our hands, I would say the vast majority of people get a transient tachycardia in the first few weeks of clozapine treatment. So it is very common. You don't necessarily need to panic when somebody has tachycardia, but of course, on the other hand, tachycardia can be a presenting symptom of myocarditis. Now, myocarditis is very rare, but of course it's very serious, and we need to check for that. The thing about tachycardia is that if it's sustained, and particularly if it continues over a 24-hour period, so tachycardia continues overnight, not just during the day, then eventually your heart muscle essentially gives up and you get a cardiomyopathy. So if somebody does have prolonged tachycardia that doesn't settle after a couple of weeks, then we do a 24-hour tape on them. And if we see a drop during the night, it drops down to normal levels, then we kind of relax a bit, because we know that that's giving the heart muscle time to recover overnight. If it's maintained, and it also suggests that it's partly anxiety driven if it's higher during the day and lower at night. If it does continue 24 hours, then you have got more of a problem. You need to start talking to cardiologists about that. If tachycardia does occur, the first thing is just to reduce the dose and retitrate again more slowly, and that sometimes helps. To decrease smoking and caffeine, and also energy drinks, which are becoming a big problem on our unit. I don't know about you, but these things like Relentless and all these things, which have very, very high levels of caffeine in them, which patients seem to love, and as well as increasing your heart rate, it also seems to exacerbate people's symptoms as well. If those sort of non-drug interventions haven't worked, then you can treat with first of all a beta blocker. So if the patient has hypertension, you can use propranolol or atenolol. If they're not, so they're thereby sort of killing two birds with one stone. If they're not hypertensive, then I would go for bisoprolol, because that's more cardioselective. So it has less effect on blood pressure and primarily affects your heart rate. There's another drug that's a more recent drug called ivabradine, IVABRADINE, and that is it's a drug that's normally used in angina, but it's a negative chronotropic, so it slows down your heart rate, but it doesn't affect blood pressure. So if you get people who can't tolerate beta blockers, either because it's dropping their blood pressure, or because they're getting headaches, or they've got asthma, or they've got other side effects, then ivabradine is worth trying, 5 to 10 milligrams a day. Yeah.
How do you distinguish myocarditis from the effects of clozapine?
It's
resting tachycardia.
Yeah. Yeah. Basically, I'll come on to that in more detail, but I might as well talk about it now. When you have a genuine myocarditis, first of all, it is extremely rare, so it is actually very unlikely to be. Of course, you need to be aware of it. A myocarditis, you generally will have chest pain, you'll have dyspnea, and or tachypnea. The patient will feel very tired and sluggish. You might have signs of heart failure, such as peripheral edema, or, as I say, tachypnea. And when you do the bloods, you'll have an increase in their cardiac troponin and in their CK. So we've actually taken to doing a baseline cardiac troponin and a baseline CK before we start people on clozapine, so that if they do develop any worrying symptoms like that, we can repeat their troponin and CK. You can only get that done very quickly and have something to compare it to. The other thing that we also do now, before we start people on clozapine, is we do an echocardiogram, because that's also very important in the diagnosis of myocarditis. So moving on to constipation. Constipation is another very serious problem with clozapine. It's under-recognised. People don't tend to report it because they're embarrassed about it, and it's very often implicated in deaths on clozapine. So our colleague Bob Flanagan over the road, who does the clozapine monitoring for us, he's involved in a lot of the inquests for people who died on clozapine, and in about half of those, the patient was found to be constipated, and frequently the constipation was thought to have contributed to or even caused the death. So people get constipated, they can get obstruction, they can get perforations, they can get toxic megacolon. They can also get reduced bowel transit time, so that they then start increasing their clozapine levels. So we were referred someone a few months ago who had walked into his CMHT complaining of feeling dizzy and feeling unwell, and he was found to have a clozapine level of, I think it was 3.6. And he developed constipation about a couple of weeks before and just carried on taking the clozapine. His levels have just gone up and up. Amazingly, he was walking around and wasn't fitting. So for constipation, the important thing I want to emphasise is to ask about it. Just make sure you ask your patients about constipation. And if you do detect it, we all know what to do about it. Prescribe stimulant laxatives. The problem with clozapine is it's the antimuscarinic effect, so you need to stimulate the bowel with things like Senna, stimulant laxatives, and a high fibre diet and exercise, of course, can also help with weight loss. Nocturnal enuresis, that's another of these sort of symptoms that people don't tend to report, and often it's the nurses that will bring it to your attention, saying that they found that the bed was wet, etc. It often persists, and we deal with it by, first of all, reducing the evening dose of clozapine and restricting fluid intake in the evenings. Desmopressin just reduces your fluid, your urine volume, so give that in the evenings. Avoiding hypertension, because that's a pro-hypertensive drug. If they're getting it during the day, then you want to go for an antimuscarinic like oxybutynin or solifenacin. Myoclonus and seizures, they're probably level dependent. Myoclonus is often a sign that people are going to have a seizure. So if they start to get myoclonus, that's a warning sign that they need to have their clozapine dose reduced, or they need to have an anticonvulsant added. So if the plasma level, the rule of thumb is if it's over 0.5 or 0.6 milligrams per litre, and if you don't have access to levels, then the rule of thumb used to be 600 milligrams a day. I'd probably add it at a lower dose than that, actually. The anticonvulsants that we tend to use are valproate or lamotrigine. We've moved more to using valproate now for several reasons. First of all, it's less toxic, particularly in women. It's less likely to cause agranulocytosis. And there's some evidence, which I'll show you later on, that it may have a synergistic effect with clozapine in reducing psychotic symptoms. Lamotrigine. Sorry, did I say valproate? Yes. Sorry, I meant lamotrigine. Thank you. Okay, so after of course, the problem with lamotrigine is a bit of a hassle to start, because you have to start it very gradually. Look out for a Stevens-Johnson syndrome. After a seizure, the drill is stop the clozapine for 24 hours and then restart it at a lower dose. And of course, if they haven't been on an anticonvulsant, add one. If they are on one, increase it or change it or add another one. And you should avoid carbamazepine or phenytoin because of the drug-drug interaction with clozapine. Weight gain, common reason for stopping. The most effective thing that we have found is adding 10 milligrams of aripiprazole to your clozapine. So there have been a couple of RCTs which have looked at that, both done by Fleischhacker's group. And it seems that not only does that prevent weight gain, it also, in people who've already gained the weight, their weight gain improves, and other metabolic parameters also improve with aripiprazole. The other thing about aripiprazole is it tends to wake people up a bit. So if people are drowsy, aripiprazole will tend to activate them. The other treatment that can be used is metformin, even if someone's not diabetic. Metformin 500 milligrams TDS. Orlistat, so that's the one that reduces your intake of, reduces your absorption of fats. You need to take that with a low-fat diet, otherwise you get steatorrhea. Low dose topiramate we used to use, don't use it so much anymore because it doesn't seem to be all that effective, to be honest. And gastric banding, we've come across one or two patients who have been, who've had we've never actually done it or referred people for it ourselves, but we've come across patients who've had that done and who've done well. So cardiac problems, I've talked about this already really, so I'm going to skip over this slide because we're getting short on time. Obsessive compulsive symptoms, they tend to have a delayed onset, so it's often in people who've been on clozapine for some time who start to develop OCD symptoms. They can respond to CBT. We've written up case reports of people who responded to CBT. SSRIs are affected probably in about 50%. Clomipramine is that, obviously with SSRIs you need to watch out for drug-drug interactions, particularly with fluvoxamine, which causes a big rise in your plasma clozapine levels. Fluoxetine also does it, but not to such an extent. Clomipramine is still the gold standard for OCD, so that's the next sort of step. There's some evidence that augmenting with sulpiride or amisulpiride or aripiprazole may also improve OCD problems. Okay, neutropenia. About 3% of people will develop a neutropenia on clozapine. It's probably not dose related, and it's difficult to predict. And if somebody has one neutropenia on clozapine, and they're re-challenged, they've got about a 1 in 3 chance of getting the second one, which actually means they've got a 2 in 3 chance of doing well on clozapine the second time. So it's definitely worth, it's often worth trying if they've made a good response to clozapine in the first place. The second neutropenia, however, is earlier, it's more rapid and it's more severe, and you tend to have a slower recovery. Agranulocytosis, sort of full-blown, affects less than 1% of patients, but when it does, it's very scary. We had someone with it last year. It has about a 5% mortality. So our approach to somebody with a history of neutropenia, which is very much our sort of bread and butter, the kind of patients who are often referred to us. First of all, we have a very strong liaison with our haematology department. We have a haematologist there, Alex Miovic, who has a special interest in clozapine-related haematology. So we will review the rate and timing of the neutropenia with him. So if you write to CPMS or ZTAS, they'll send you through a graph like this showing the person's blood counts over time. And the warning signs, if it's a genuine clozapine-related drop, is it tends to occur early. Most of them occur, about 80% of them occur in the first 18 weeks. Tends to happen suddenly, so that it can be relatively normal and then suddenly drop. It recovers quite slowly, and the cells are, the neutrophils, when you look on a blood film, are morphologically abnormal or immature. Benign ethnic neutropenia is something that we've become much more aware of recently, particularly in this area where we have a high population of people of African Caribbean origin. So a proportion of people of African ancestry have a natural low neutrophil count. So it's not pathological, it's benign, but it prevents them from being able to take clozapine because it means that their neutrophil count is below below the amber level. So particularly in those cases, we will, that's just a paper about benign ethnic neutropenia. Particularly in those people, we will try and boost their white count artificially. And we do that with usually first line with lithium. If you achieve a plasma level of 0.6 millimoles per litre, then that in most people will increase the white count. In our experience, it doesn't actually tend to work all that well in benign ethnic neutropenia. We're not quite sure why that is. The other thing that we're using increasingly is GCSF, granulocyte colony stimulating factor. That is it's obviously a naturally occurring cytokine, but which can be given artificially as a subcut injection. It stimulates neutrophil production from the bone marrow. It probably doesn't protect you from a neutropenia, and there have been case reports of people having a full-blown agranulocytosis and getting septicemia and getting very ill when they were on GCSF. So it's not protective, and neither is lithium. The other slight worry about GCSF is about leukemia. So when you look at the epidemiology of people who've been on long-term GCSF, they do have an increased risk of leukemia. But what we think that probably is actually confounding by indication. In other words, people are often put on long-term GCSF because they have a hematological condition which in itself predisposes you to leukemia. So when you just look at people who've been put on GCSF for an apparently benign or idiopathic neutropenia, there doesn't seem to be an increased risk of leukemia. So that's something that we're doing increasingly. We've got two kind of protocols. One is for people who their white count sort of bobs along just above the amber range and sometimes dips down. For those people, we'll give them a shot of GCSF when they go into the amber range just to bring them back up again. And then we have another group of patients for whom they have to have regular GCSF, and they have it once a week or sometimes twice a week, depending on the preparation. Because without GCSF, even if they're not on clozapine, their white count will be less than their neutrophil count will be less than 2.
James, just got a minute left.
Sorry, we've just got a minute left. Okay. In that case, I'll open that to questions then. Yeah.
Thank you very much, James, and good to allow people at least a little bit of time for some questions. Have you got any burning questions that you wanted to ask about how to manage clozapine? I want to know about partial responders.
Okay, well that's
I'll come back next year.
Okay, well, in a nutshell, if there was a magic thing that worked on everyone and that had good evidence for it, we'd all know about it. So I think we all know that there isn't anything with a really good evidence base after clozapine. The options are probably the options that we use the most and that we have the most faith in are high dose olanzapine. So there've been a number of studies. A lot of them have been industry funded, but which have shown that high dose olanzapine, and we're talking about doses of sort of 35, 45, even up to 60 milligrams of olanzapine in one study, can be almost as effective as clozapine. And we've had some people who've done quite well on that, particularly people who've responded. It seems to work in people who've responded to clozapine, but who then can't take clozapine. And so those people can, you can prescribe high dose olanzapine. Obviously that's a very risky thing to do, medically, etc., and you have to make sure that you're very cautious about about weight gain and diabetes and all these other problems. The other thing, in terms of augmentation, probably the thing with the best evidence is actually lamotrigine. So we used to always augment with another antipsychotic. The evidence on that is kind of a bit iffy. It's probably still something that it's still something that we do sometimes do in desperation, but we don't do it as sort of first line anymore. The first thing we do to someone with clozapine who's not responding is to add lamotrigine, and that's because there was a meta-analysis. I think there's been more than one meta-analysis that's shown that of all the augmentation strategies, lamotrigine is probably the one which is the most efficacious in terms of reducing psychotic symptoms. Most of that's actually down to just one study, but actually that was probably the biggest study that's been done, and it was a well-conducted study. The last thing, just finally, is ECT. If you look at the NICE guidelines, they are very sort of negative about ECT in schizophrenia, and say that there isn't any evidence to support the use of ECT in schizophrenia. However, the Cochrane review on the matter comes to a very different conclusion and says that there probably is some evidence for the use of ECT, that it doesn't necessarily only work in people who are catatonic or only in people with affective symptoms, and also that it gives some recommendations about the dose. So you should give at least 1.5 times the threshold for the seizure threshold, and you should give up to 20 treatments before you say that it hasn't worked. There's also a very interesting study which isn't published yet from New York, where they've looked at people who are on clozapine and haven't responded, and they randomised them. It wasn't blinded, but they randomised them to either ECT or to nothing. And an astonishing proportion of the ECT people responded. I think it was 60% or something, whereas virtually none of the people who were just remaining on clozapine were. So this is an area which I think needs more research. There's a presentation which has been made to the NICE guidelines people, so in the hope that in the next NICE guidelines ECT will be recommended for treatment-resistant psychosis, and it's something that we're using more and more of in the National Psychosis Unit.
And that's the final thing you should do, which is refer them to the National Psychosis Unit. If all else doesn't work, make it James's problem and not your problem. Anyway, thank you very much, James, for that fantastic. So James's slides should be coming round, so you will get a chance to look at the rest of what he was going to say about partial responders. But that is a whole topic in itself. It's a great pleasure for me now to introduce Professor David Taylor, who is the Professor of Pharmacy and head of the King's Health Partners Pharmacy Department. And he is going to give us a talk about what's new in the pharmacy. So this is unknown to me as well, so I'll be very interested to hear what's coming out of the pharmacy now. Thank you, David.
Thank you, Ulrich. Now, in anticipation for this talk, I thought I'd invite you to participate, because I'm somewhat afraid that I'm going to be telling you stuff that you already know and are rather bored by. My feeling that this might be the case has been increased when I spotted some very learned colleagues in the audience who probably know more about psychopharmacology than I do. So if I could ask you, as I go through these drugs, to put up your hand with some alacrity when I ask you questions about whether or not you've heard of them or used them, it will enable me to determine how much time I spend on each of the drugs. So you'll be aware that research into